I'm just going to give you a big overview on Chiari Malformation and Syringomyelia. So this would be kind of just a beginning overview of the two different topics, which you'll see a lot today. This is a normal brain MRI and cerebellum position, and I'm kind of denoting here this white line is the opening of the foramen magnum. So this is the, below this is the spinal canal, and everything in the brain should stay above this white line. So this is the cerebellum here, and you can see it's positioned above that. But what happens in a Chiari malformation? So this is MRI, so this is a sagittal view. You can see this is the cerebellum here, and this is a blown up view of that, and you can see it's pushed down into the canal, and it's pushing on the brainstem, and it pushes the brainstem down even further. Okay, so this is causing brainstem compression. It's obstructing the outflow of normal CSF, which begins up in the brain, flows through the aqueduct in the fourth ventricle, and it can't get out here. And then this ultimately results in symptoms: brainstem compression, obstruction of CSF flow, and other things that can happen, like Syringomyelia, which we'll discuss. You can see the difference right here. All this black here is CSF in this picture. You can see all the normal fluid around here, and the tonsils of the cerebellum are rounded. You can see here they're pointed, and they go down and kind of plugging this whole channel. So just a quick overview of Chiari malformation. It's a congenital developmental abnormality. 2 to 4% of the population has this, so it's quite common. And it's really not thought to be an abnormality in the cerebellum. It's a bony problem, intradural scarring problem. Usually occurs before 5 years of age. We have patients that present, though, from infancy, below 1 year of age, to 70 years of age. And symptoms are extremely varied. The most common, though, we think of is this headache, this Valsalva occipital-induced or occipital-Valsalva-induced headache. The typical kind of radiological criteria is this more than 5 millimeters below this opening. We call it a Chiari malformation, although that can vary just depending on the patient's own anatomy. This you can see here is a syrinx as well. So what causes a Chiari malformation? And so I think what you'll hear a lot, I think, in the next 3 days is what you just heard from Paulo, Dr. Bolognese, is that there's a lot of nuance to this. We don't have all the answers. And so we as physicians are still searching for the answers of what causes these conditions, what's the mechanisms, or what we say in medicine is the pathophysiology. So from the literature, there's a substantial amount of literature that says there's a decrease in the posterior fossa volume for Chiari. So this is the posterior fossa, this area back here which holds the cerebellum. And it's just not enough room, okay, to hold the cerebellum. So some of it has to go down into the spinal canal. And that's what you see here, right? So this part of the cerebellum's going in. And you can see how crowded it is, right? It's small in this case. There's not much room for it. You can see there's flattening of the cerebellum around here, and then it's forced to go into the spinal canal. However, in some cases, there's really not. Some other literature has shown that really posterior fossa volume is not small. And you can see oftentimes there'll be a CSF cap, which is above here, the cerebellum. And so there's tons of room in some cases above the cerebellum with CSF. Why can't the cerebellum just be sitting up there? And so there's probably other mechanisms beyond just a small posterior fossa to cause a Chiari malformation. And one of the things you saw with Dr. Bolognese's talk on IIH is similar in Chiari and similar all these conditions, is that likely all these conditions the mechanisms are heterogeneous. There's multiple different types of mechanisms that are causing all what we see on imaging, which all look similar, yet there's a lot of nuance in terms of what maybe is causing the Chiari in someone who's 1 year old or infant versus someone who's 5 or 10 or 25 or 55. So was another cause of a Chiari malformation, or what contributes to this tonsil herniation if there's a lot of room still here? This is data that we've shown and others have shown. There's a lot of scarring that does occur inside the dura, right, around the cerebellum, around the brainstem, that blocks fluid flow. So it blocks the outlet down here where a lot of the scar tissue is. So fluid can't get out here. You can kind of push the cerebellum even down further into this channel because you have that scarring and adhesions, we call them. And so that then can leave this top part a little bit more spacious because you have this whole cerebellum being pushed down into this canal because fluid can't get out. So the scarring, you can see here, this is the outlet of the fourth ventricle. It has this glistening appearance. That's because there's this scarring completely over it. It's a little thin membrane. There's all these adhesions between the cerebellums. There's adhesions that go between the cerebellum and the brainstem. Here and here, there's also oftentimes these large branches of the pica. They're called a vermian branch of the pica that will go and also narrow this outlet of the fourth ventricle. Here's a complete occlusion of the fourth ventricle, and this has to be opened up. Oftentimes we see this more in patients with syrinx than without syrinx. We think this could be is caused by maybe some blood that pools around the cerebellum during time of birth. And blood we know is very inflammatory and causes scar tissue to form just like this. It also may be part of the tonsils have descended somewhat already, and then because of the piston effect, every heartbeat, the tonsils go in further down and up and down, up and down. That ultimately causes scar tissue because tissue is rubbing together. And so this can be challenging because you have to try to open up these pathways in these cases. Otherwise, you won't get an adequate treatment response. So a question people always ask is, does Chiari malformation change with age? The tonsils they can ascend in young children, kind of really young, but 1 to 3 years of age as they age. So we'll see a lot of children. That 2 to 4% population of Chiari includes a lot of these kids where the brain's very full. The brain is really growing a lot in the first couple years of life, and the skull is just responding to that brain growth. So the brain is growing almost too much, then some of the cerebellum will descend below into the spinal canal. So this is a report, and there's been many reports of this, of just a spontaneous resolution of a Chiari malformation. So here's a tonsil descent down here. It's harder to see on this projector, but then it does ascend above this white line as that child ages. So that's one. After the child gets to 5 years of age, a chance of it probably ascending is much less likely. Okay, this is something that we see like in really young kids. We see maybe they have 5 or 6 millimeters of tonsil descent, and then that will, as the skull grows, as the spinal canal elongates, the brain has then more room to fill. On the other hand, we also can see that the subdural tonsils can descend as one ages as well. Okay. Usually, again, this is a young phenomena, right? So this is the development of a Chiari malformation, over time in this child. So here's 2 years of age. Child has an MRI. I forgot for what reason, but this is probably incidental. So they had some kind of fall trauma, and then you can see the bone thickens up here in this child. They're found to have these bony abnormalities as well, but this bone is thickening up, and in the next 2 years, the space gets a little bit smaller. This space here, where this opening the spinal canal gets more narrowed, and then the cerebellum just plugs this channel. CSF can't get out through here, and I think that just makes the descent even worse, the tonsillar descent, and then cause a Chiari malformation and ultimately a syrinx in this child's case. You can see just the top of it there. All right, so what do we know about Chiari malformation and Syringomyelia? Well, we know that Chiari malformation can cause a syrinx or a Syringomyelia. So it blocks the fluid flow here, the tonsil descent. The fluid can't get out. So there's really only one place where it can go, and it's got to go into the spinal canal. The spinal canal, in some people, they have this dilated central canal that's persistent. There's a potential space that in some people just stays open after birth. And so that gives this channel here for fluid to go into. And so then fluid can enter into that channel and cause a fluid cavity in the spinal cord. Another mechanism is the thought that there's just increased pressure in the entire spinal canal, and that CSF then can enter anywhere along the spinal cord, from the cervical spine, the neck, all the way down to the lower back. This syrinx then weakens the nerves that are coming out of the spinal cord. And those nerves are going to the muscles around the spinal column, the vertebra. And if those muscles are weak, then the spinal column itself doesn't have enough stability. And then that can lead to scoliosis, which you see here. Okay? So that leads then to a curvature of the spine. And again, this is only in children and teenagers. Right? Once the spinal column is completely grown, this scoliosis can't really occur due to a syrinx. So this is really primarily a pediatric issue. Scoliosis, that is. Syringomyelia occurs in 45% to 68% of surgical cases. Okay, I state that because we really don't know over a large population of just Chiari malformation itself how often syrinx occurs. Probably a lot less. Okay, so these are symptomatic cases, and it varies. It just depends on referral patterns and such. Okay. The interesting thing about the syrinx associated with Chiari malformation is that people can have very similar findings on imaging. So they can have similar tonsor descent, same kind of anatomy, tonsor descent, yet they'll have a syrinx in one case, but not a syrinx in the other. So these are two different patients. So that's why the obstruction and how severe the obstruction is of a Chiari malformation doesn't also necessarily lead to, oh, they're going to have a syrinx. There's more factors that are in play here. Is more the mechanism. And one of those mechanisms probably is, this is likely, we don't have evidence for this, but likely is someone having that persistent dilated central canal after birth. So if there's a potential space for fluid then to enter. Without having that space, then it's harder for fluid likely to enter that canal in the middle of the spinal cord and have a syrinx. I think the worst Chiari malformations in the sense I've seen of like 30 millimeters, those patients never have it. None of them have had a syrinx, right? So it's not about how severe the tonsor descent is or how severe the obstruction is. It's likely other factors within the spinal cord itself and also the CSF flow dynamics that lead to a syrinx with a Chiari. So for the symptoms of a Chiari malformation, this is a big long list and there's way more than this. I highlighted in pink just the ones that I see the most commonly, okay? And they're by mechanism. So you get this obstruction of CSF flow, and you'll get a Valsalva or strain-induced occipital or upper cervical kind of pain or headache. So Valsalva maneuvers are straining, laughing, crying, sneezing, and it occurs right back in the back of the neck here, right below the occipital, that bump you feel in the bone. That's what you'll feel. And that pain then can radiate to the front of the head and can radiate down the neck. And then some patients, they'll just complain of a Valsalva-induced headache, but maybe the headache is more in the forehead. Okay, that's pretty classic. Then you get compression of the brainstem, cerebellum, and the cranial nerves. Okay, and that will lead then to swallowing problems. That's probably the next most common symptom I see, and that's oftentimes when you see a little bit of that brainstem compression, because those nerves that go to our swallowing muscles are all there. Some absent gag reflex you'll see on exam, and then swallowing problems are also because of this. This because of a lack of a sensation in the back of the throat. You'll have sleep issues, so snoring during sleep, obstructional sleep apnea, or central sleep apnea. You get hoarseness and also dysarthria, not as common. That's kind of rare. And then kind of when there's really kind of persistent and severe brainstem compression, you'll get this downbeat nystagmus. And that's I feel like once we get to that, we're kind of getting to we're getting to the end of the symptoms here. This is severe. The other thing I would say is also, this trigeminal sensory loss. I'd see that oftentimes before I see downbeat nystagmus, so like a loss of sensation in the face because the sensory fibers to the face are in that part of the brainstem and go to the upper cervical spinal cord. So that's compression from the cerebellum. Then you get syrinx. The symptoms from a syrinx are from the dilation of the spinal cord and then weakness of those muscles, weakness of the nerve roots that are out there, compression of the nerve roots that don't function as well. So you get this kind of motor weakness, and that's out to the arms, hands, like cape-like distribution, less in the feet, less in the legs. Eventually that leads to atrophy. You'll see atrophy, and this is after long standing. It can happen kind of quickly in some people, but oftentimes it's after like many years, and you'll see atrophy of the hands, you'll get weakness, and then spasticity, where legs don't function as well, hard to ambulate, and then weakness in the hands themselves, and maybe jerky movements of the legs, and that can lead to people being more wheelchair bound, having to use some kind of assistance for walking, and so forth. Those are the symptoms, but they do vary by age. So very young children, swallowing problems, may fail to thrive. They may be very thin. These are even infants could have problems. And in those cases, it's, it can be almost an emergency to kind of do a Chiari malformation, at least within months, just to, so they can swallow more normally. Children, difficult. Children may not complain about a headache. They can't express themselves. So how do they express themselves? It's oftentimes these are valsalvinous headaches, so that can lead to issues with trying to have a bowel movement. So they can have constipation or abdominal pain. So again, just going over the symptoms, suboccipital headache, worsened by valsalva maneuvers, coughing, sneezing, laughing, crying, straining, exertion, playing outside. That can be common in kids because they're more likely to do rather than like lifting something heavy, right? Straining. And then signs. So signs are different. Those are things we look on exam. So lower cranial nerves. These are the brainstem and cerebellar findings. Again, that impaired gag response. So very sensitive, very, very sensitive. And so there's someone that has even just like a little bit of a tonsillar descent, brainstem compression, you'll see this kind of facial sensation loss. That's cranial nerve 5, and hoarseness is not as common, but the 10th nerve. And then these syrinx-associated findings, you can have either increased reflexes or decreased reflexes. It just depends on the patient's anatomy and how big the syrinx is, where the syrinx is located. Typically, I think of if it's a big, long holocord syrinx, the entire spinal cord is distended. Those patients often have decreased reflexes because the nerves are already so much affected that the reflexes are going to be absent in the arms or legs. You get this atypical scoliosis. So here at Iowa, and I'm pretty sure everywhere now, if someone presents with scoliosis, they get an MRI. So a child, teenager, they always get an MRI to make sure there's not something else causing the scoliosis besides the idiopathic version, which is your common adolescent scoliosis, which we don't have exactly the cause for. That term idiopathic, again, is for unknown cause. But atypical scoliosis is a different curve than the typical curve that we would see in adolescent scoliosis, also much younger age. You get this, again, weakness, atrophy, arms, hands, balance problems, and decreased sensation of light touch or pinprick. So question always is asked, if this occurs in development, like I said, all these from it's classic Chiari malformation, congenital Chiari malformation, why does it take some people so long to develop symptoms? So it's still unclear, but some symptoms are subtle, so they're not noticed by the patient. I had one adult patient years ago who had a Chiari malformation, holocord syrinx, very, very large syrinx. The cord it dilated all the way out to the spinal canal. And after surgery, she did well. Syrinx decompressed, and she did great. And she said, but I had this, whenever I would cough or sneeze, I get this pain that would shoot down my back my entire life. I thought that was just normal. I thought everyone just had that because this violent sneeze, and people have pain with that. And after surgery, that went completely away. And so some people take some of these symptoms and they say, that's just my life, right? That's how we all are. So that's one component of it. It's also dynamic, Chiari malformation is. So the tonsil herniation may be worsened by weight gain, Valsalva maneuvers, weightlifting, jobs that require lifting, etc., and that increased Valsalva maneuvers, although you may not see a big change on imaging in terms of like the tonsillar descent. Okay, you might see a little bit more impaction, and all it takes is just, I think, a little bit more obstruction of that CSF flow, and then patients then have more symptoms. Or they get in a car accident or something, and then a little bit more scar tissue forms, like I showed you before, and then they start having the headaches. And this is like an adult, right? So never had problems before, or very subtle signs, right? But then things worsen as an adult for some kind of inciting event. So what's the treatment? Well, observation, surgery, medical, lifestyle management, these are all different possibilities, right? So surgical treatment, posterior fossa decompression, small bone removal, and a compressive band removal. And if syrinx or tonsil herniation is severe, there's brainstem compression, and you can open the dura, decompress internally, remove scar tissue, open up the CSF pathways, and expand the dura with a graft. These are the kind of classic treatment strategies for this. So it's a midline incision. There's a opening of the skull right here. Historically, people would have a very large skull removal, and over time realize, well, the main problem is down at the foramen magnum, right? So a smaller opening here in the skull than we used to do in the past, and then take off C1 or part of C1. That gives you access to the dura here. You can open up this compressive band that's here, and then open up the dura and do decompression inside, take down that scar tissue, make sure the CSF is flowing normally out of the fourth ventricle here, and then place this dura patch. And people will oftentimes use some kind of dural sealant. It just helps prevent CSF leak and protecting this so it can heal better. So this is like a pre-op image. It's a post-op image. You can see the tonsillar descent, Chiari malformation here in syrinx, and then you have this, and there's no CSF. The white here is CSF. There's no CSF around the brainstem, no CSF around the cerebellum. And then afterwards, you see this nice expanded, a little bit expanded dura, okay, here. And you have this nice white CSF cleft around the cerebellum. The cerebellum is floating in here nicely. There's CSF now in front of the brainstem. There's no more compression on the brainstem. CSF can flow normally, and then you no longer have the syrinx that's here. So who's a candidate for surgery? So some people use a strict, criteria of Valsalva-induced, headaches. I would say that is, quite common, although this is one thing. You have headaches that are kind of Valsalva-induced. You have this radiological appearance obstruction of CSF flow, and then neurological findings, right? So some patients won't have headaches, right? They might have symptoms of brainstem compression. They have symptoms of a syrinx and so forth. So everyone's really different in terms of surgery. Obviously, what you want to do as a surgeon and as a patient is, are these headaches? If all you have is headaches, that's the only thing, right? And say the Chiari malformation is maybe it's not causing brainstem compression. It may be not as severe as others that you've seen here. Is the headaches from the Chiari malformation, right? That's the question. And so that requires a lot of detail, and I think one of the talks by Dr. Vez will kind of go over that in a little bit more detail. But you want a lot of causes of headaches like migraines and cluster headaches and so forth. So you don't want to operate on someone to help treat their headaches and they still have headaches after surgery because it's from a migraine, for example. So what are other causes of tonsil herniation? We call this acquired Chiari malformation. So this is not something congenital. They haven't had it in development. And that's from hydrocephalus. That's one thing. So there's increased pressure in the brain. You can get tonsillar descent. As you can see here, this patient got shunted. And it's a child, actually. This child got shunted, and you can see the tonsils went up, ventricles came down. I think this child had a syrinx, too. That went completely away. So other space-occupying lesions or masses or tumors. The goal there is to treat the tumor, treat the mass, take care of the intracranial pressure, and then you hope that the tonsils will ascend. It's not always the case that they will in these kind of cases, and you still may have to do a Chiari decompression, but that's the first strategy in treating these kind of patients. Also, a spinal CSF leak can cause intracranial hypotension, and that can kind of pull the whole brain, including the tonsils of the cerebellum, down further. And then the goal there is to treat the CSF leak. We'll have a talk on that, or a couple of talks on that as well. So these Chiari malformations, again, they're complex. They can also be associated. These are congenital ones. Okay, so now going back to congenital Chiari malformation, they can also be associated with these craniocervical bony and ligament abnormalities. So these are patients with kind of connective tissue disorders. As you mentioned, Dr. Bolognese mentioned, some of these patients with Chiari, maybe 1 out of 5 have connective tissue disorder or bony abnormalities, or they may be combined to have both. But these are all congenital abnormalities. You can see the bone here, the second bone is much higher than it should be. This is the clivus, the skull base. It's fused to the first bone of the neck. The second bone here is fused to the third bone. You can see all these different abnormalities. And then you can see there's this, it goes with this patient. This is compression of the brainstem pretty significantly here, and then tonsillar descent. So another case over here, you can see that this is the skull base. It's very small. And then there's fusion of the first bone with the second bone, and there's this compression in front, from the bone in front, not just from the back. And so these cases where there's this bony problem in front, These patients oftentimes will have compression you can see from in front here on the MRI and in the back from the tonsils of the cerebellum. So having a bony compression problem in front, they're having the tonsils of the cerebellum compressing in the back, and they can lead to all different types of symptoms. Oftentimes these patients are unstable, meaning that this is dynamic. This is pushing in certain positions when they're flexing their neck, and they're being more relieved when they're extending their neck. And these patients oftentimes will require a fusion surgery to stop that motion. And so that's a fusion from the occiput down to oftentimes C2 or even further, just depending on their anatomy. So you can see this is a decompression here, and then we use a rib graft, and we fuse that down to the second bone. These are screws in the skull, screws in the second bone. We'll be talking about that later. So again, now we move on to Syringomyelia. So what is Syringomyelia or syrinx? And I was putting this together, this talk. I went on Google and I typed what is Syringomyelia. It's interesting. You'll see different things. A lot of websites describe it as a cyst. I was surprised by that. I only think of syrinx as a cyst. Okay, it's not a cyst, in fact. But maybe that's the best way to describe it to everyone as a patient. But that's not. It's really just a fluid-filled cavity within the spinal cord. Oftentimes, again, it's that dilated central canal that enlarges, especially in the case of Chiari malformation, and it's for all different causes. The spinal cord is distended, and this can cause damage and neurological deficits, like I mentioned before. All right, so normal spinal cord MRI. This is what you see. This is this brainstem here. It's a sagittal view on an MRI. So looking from the side view of the spinal cord on an MRI, you can see the brainstem is gray here. It goes gray all the way down. It's just like a nice cord. There's white around that as fluid, and it surrounds the spinal cord. Okay, it's a 2-month-old. This is an adult. Here's the cerebellum. These patients don't have a Chiari malformation. They have normal anatomy. So brainstem, good CSF around here, and a normal just cord of gray going straight down. Okay, that's what a normal spinal cord MRI looks like. Just keep that in mind. We'll show you what the different causes of Syringomyelia and what it leads to. So Chiari malformation is one. We talked about that earlier. Tethered cord. So that's pulling down of the spinal cord itself. So it's held in place and it can't move in the spinal canal like it should. So it can lead to damage over time, especially with movement, flexing, bending over, things like that. Tumor, often can be associated with a syrinx, and sometimes very large syrinx. Or CSF blockage, so arachnoiditis, which we'll have talks on, and trauma, which is associated with this as well. We'll have talks on that as well. So this overview, this is a Syringomyelia from a Chiari. You've seen this, but this is just showing you the spectrum. So 2-year-old girl, Chiari malformation, large syrinx here. 6-year-old girl, this is scoliosis, and tonsor descent, obstruction, brainstem compression, very large syrinx. You can see the scoliosis even on the MRI because you get this, you don't see the entire canal all the way through because it's out of the plane of the MRI here on the sagittal view. It's a 37-year-old woman, an adult. Again, large descent of the cerebellum, tonsils, and syrinx down here. So span the spectrum here. Syringomyelia from a tethered cord. I guess I would tell you, so as you can see, syrinx, right? This is a big fluid-filled cavity right in the spinal cord. It's not that nice kind of gray line going all the way down, cord all the way down. So tethered cord, that also can cause a syrinx, though it's oftentimes very different in appearance than the Chiari malformation type syrinx. Oftentimes it's further down, so further down the spinal cord. It's not at the top at the cervical spine, so further down. And this is a case where the spinal cord ends here. This is a tumor that was in the spinal canal itself that caused a bunch of scar tissue, and it caused this child to become paraplegic. This child survived this tumor from surgery and then ultimately chemotherapy. But the cord became tethered here, and this is just from compression and scar tissue within the spinal cord from this tumor. And it came right to here. And you can see what happened. They have this syrinx that's forming here. You can see this dilation of the spinal cord. This patient presented with this is a child, it's a 3-year-old girl, presented with severe pain. Just along the whole back. and every single day, multiple times a day. And we released this here, and then ever since we released that, that child has had no more back pain instantly. So the other cause of Syringomyelia is tumor. This is a 29-year-old woman I saw, I think, in 2018 or 2019. She had surgery elsewhere. Initially, she had a syrinx. It was not this large, but this whole white cavity is a syrinx. So you barely don't even see the spinal cord in this case. And it goes all the way down to here. Initially, they thought, and I could show you something, they initially thought it was a disc here, herniation, that was causing the syrinx. And it was close to that. But that disc was not big enough and did not cause that problem. And this patient was treated elsewhere. First got an ACDF by another surgeon, thinking that was a problem. And this is a tough case. But I'll show you this case here. I'm not seeing this woman yet in clinic, but I'm going to be. I saw it in my clinic schedule. I figured I'd put that here. But you can see this little disc here. And yeah, maybe it pinches here, and some might think, oh, is that the problem? But clearly, this is the problem up here. But that would be the case where someone thinks, oh, there's a syrinx, I should go and do a cervical decompression and fusion here, thinking it's going to take care of that. In some cases, it can be quite severe, and you're thinking, man, is that the problem? But really, in a case like that's the problem. So that was the first thing that was done. It did not help. The syrinx got bigger. The next strategy, they thought this patient has a Chiari malformation. The patient did not have a Chiari malformation, but there's a condition called the Chiari 0, where you don't have to have descent of the tonsils. Usually we see that in kids, though, and usually there's definitely obstruction here. There really wasn't, but they tried to do that here. That didn't help. Third strategy was to do a syrinx subarachnoid shunt. So that's why there's this little defect here. This was a bone that was removed here, laminectomy, and a little tube was placed here into the fluid cavity out, and that did not help either. The next strategy they were going to do was so the fourth surgery was going to be a syrinx to pleural shunt. Okay, and so then this woman and her husband came to see me at the university. Said, okay, what do you think about that? I said, well, geez, it seems like there's some other cause for your syrinx. We should find the cause, right? Like I said, every single one of these has a cause. I'm going to point to you, right, this little dot right here. That is a tumor causing all of this. And you can see there's other little white spots here and here and here, but when you really look at this and look at all the scans, this is just a little bit inside the spinal canal. And this is a hemangioblastoma. And they don't have to be that big. They can be, this is millimeters. And that was causing all the problem. So that was just, we did another laminoplasty here, take off the bone, replaced it, and took that out, and this entire syrinx is completely resolved after that. So these symptoms, I kind of gone over this already. I guess the biggest thing is that I want to reemphasize this kind of sensory changes, which I don't really mention as much, but you get this loss of sensitivity to pain and temperature, and it's the hands, arms, and like upper chest and the top part of the back. You see less of that in the legs. Balance problems, you get muscle spasm or stiffness. You can have bowel or bladder issues, weakness, muscle atrophy, and pain, like that 1 3-year-old I showed you. The treatment is really underlying cause. Treat the underlying cause. Chiari malformation, tethered cord, tumor, and then if it's arachnoiditis, intradural adhesion, and scar tissue, you need to open up those CSF pathways. And that's it for the intro. Thanks.